If you are currently taking your blood pressure medication alongside your morning coffee, I need you to give me your full attention right now. And if you are taking a water pill, a diuretic, in the late afternoon or evening, that applies to you as well. And if you have ever doubled up on your dose after missing one, I want to address that directly because what I am about to share with you is the information your pharmacist should have provided the day you filled that prescription. I am going to walk you through the most dangerous timing mistakes people make with blood pressure medication. I see these patterns every single week in clinical practice, and they rarely get addressed during a standard appointment. If you are taking your blood pressure medication in the morning or at night without understanding these specific principles, you may be cutting its effectiveness significantly. Or worse, you may be creating a window of time during which your heart and kidneys are not adequately protected. What I'm going to cover today is the conversation that should happen after the prescription is written, but too often does not. Stay with me through all 5 points because timing mistake number 3 is the one that catches most people entirely off guard. I am Dr. Lee. I have spent 40 years in clinical medicine, and I created this channel because the information that protects lives in my practice should not be confined to that setting. Blood pressure medication is one of the most frequently prescribed drug classes in the United States, and the vast majority of patients are told what to take, but not when to take it, not what to avoid taking it with, and not how to manage a missed dose. That gap in guidance has real consequences for real patients, and today I intend to close it. Let me begin with one of the most commonly prescribed classes of blood pressure medications, ACE inhibitors and ARBs. Drugs such as lisinopril, ramipril, losartan, and valsartan are taken by millions of patients every single day. For decades, the default clinical instruction was to take these medications once daily in the morning. That was largely a convention, not necessarily grounded in evidence. And over time, the research has told a more nuanced story. Studies have shown that patients who took their antihypertensive medication at bedtime had meaningfully better cardiovascular outcomes than those who took it in the morning. Lower rates of heart attack, lower rates of stroke, and lower rates of death from cardiovascular causes. The underlying reason for this is important to understand. Blood pressure follows a natural circadian rhythm. It decreases during sleep and then rises sharply in the early morning hours, a phenomenon we refer to as the morning surge. That morning surge is the period of greatest cardiovascular vulnerability, when the risk of heart attack and stroke is statistically highest. A medication taken at bedtime remains pharmacologically active during that critical early morning window. A medication taken in the morning, however, may have already reached its peak and begun declining in effect before that vulnerable period even arrives. I want to be transparent with you. The science on this continues to evolve, and the optimal timing depends on your specific medication and your individual blood pressure pattern. Some studies show a clear benefit to bedtime dosing. Others show no statistically significant difference. What I tell my patients is this: ask your prescribing physician one direct question: should I be taking this medication at bedtime rather than in the morning? That conversation is worth initiating, and if your physician has not previously considered it, that itself is useful information. The second timing concern involves something many patients have in their kitchens every morning without any awareness of the risk. Grapefruit and grapefruit juice contain compounds called furanocoumarins, which inhibit a critical enzyme in your digestive system known as CYP3A4. That enzyme is responsible for metabolizing many blood pressure medications, most notably calcium channel blockers such as felodipine, nifedipine, and amlodipine. When that enzyme is inhibited, your medication is not processed and cleared normally. Blood levels of the drug rise significantly, sometimes reaching dangerous concentrations. The clinical consequence is an exaggerated and potentially severe drop in blood pressure, leading to dizziness, fainting, and in some cases, dangerous cardiac arrhythmias. What makes this particularly important is the duration of the effect. Grapefruit's interaction with this enzyme can persist for 24 to 72 hours after consumption. This is not simply a matter of the moment you eat it. A glass of grapefruit juice in the evening can influence how your medication behaves the following morning. If you are prescribed any calcium channel blocker for blood pressure management, I encourage you to ask your pharmacist directly, is grapefruit a concern with this specific medication? Do not assume the answer is no. Ask explicitly. The third timing issue is one that surprises my patients more than any other, because it has nothing to do with drug interactions or dietary choices. It involves something far more straightforward, and yet the consequences can be quite serious. Diuretics, commonly called water pills, are among the most frequently prescribed components of blood pressure treatment. Medications such as hydrochlorothiazide, furosemide, and chlorthalidone work by prompting the kidneys to eliminate excess fluid, which reduces circulating blood volume and lowers pressure. The timing problem I encounter regularly is this. Many patients are taking their diuretic in the late afternoon or evening, sometimes because they forgot the morning dose, sometimes because they were never given specific timing instructions. When a diuretic is taken too late in the day, the predictable result is frequent urination during the night. Many patients accept this as an unavoidable side effect. It is not. It is a preventable consequence of incorrect timing. But beyond the disruption to sleep, I want you to understand why this matters at a deeper level. Every time an older adult needs to get out of bed in the middle of the night, in the dark, sometimes disoriented, with blood pressure that may shift significantly upon standing, the risk of a fall increases considerably. Falls at night in older patients are among the leading causes of hip fractures, and hip fractures in adults over the age of 70 carry a one-year mortality rate of 20 to 30%. That is the real clinical consequence of taking a diuretic at 6 in the evening instead of 8 in the morning. My standing recommendation to every patient on a diuretic is this: take it in the morning, ideally before 10 o'clock, so that the peak effect occurs during waking hours. If you are prescribed a twice-daily diuretic, the second dose should be taken no later than 2 in the afternoon. The fourth timing consideration involves beta blockers, medications such as metoprolol, atenolol, carvedilol, and propranolol. Most patients who take these medications take them in the morning, often alongside or shortly after a cup of coffee. Here is what is occurring physiologically when that happens. Caffeine is a central nervous system stimulant that activates your sympathetic nervous system, raising heart rate and temporarily elevating blood pressure. Beta blockers function by blocking precisely that sympathetic activation, slowing the heart rate and reducing the contractile force of the heart muscle. When you take a beta blocker at the same time as a significant quantity of caffeine, you are essentially pressing the accelerator and the brake simultaneously. In most patients, the medication prevails. However, in patients with a history of cardiac arrhythmia, this combination can provoke palpitations or irregular heartbeats during the period when caffeine concentration peaks in the bloodstream, typically 30 to 60 minutes after ingestion. There is also evidence suggesting that caffeine can interfere with how certain beta blockers are metabolized, particularly metoprolol, in individuals with specific genetic variants affecting drug processing enzymes. My clinical recommendation is straightforward. If you are taking a beta blocker for blood pressure or any cardiac condition, allow at least 30 to 45 minutes between taking your medication and consuming coffee. It is a small and simple adjustment, and for patients with a history of arrhythmia, it may carry genuine clinical significance. The fifth timing mistake is the one I encounter most frequently, and the degree of risk it carries depends entirely on which specific medication is involved. A patient misses their morning blood pressure dose. They remember at noon, or 3 in the afternoon, or at dinner. The natural instinct is to take 2 doses that evening to compensate. For some medications, this carries relatively limited risk, but for others, particularly calcium channel blockers, certain ARBs, and beta blockers, doubling a dose can produce a sudden and substantial drop in blood pressure, causing dizziness, fainting, and in older adults with reduced vascular tone, a serious fall. There is a second and equally common version of this mistake that I see in practice. Patients who are prescribed twice daily medications begin taking them only once daily because it is simpler to remember, often without informing their physician. The blood pressure appears partially controlled. The clinical numbers look acceptable at the next visit. The medication dose is never reassessed, and the cardiovascular protection that patient is entitled to remains incomplete. The guidance I provide to my patients is consistent and clear. If you miss a dose and it is still the same calendar day, take it as soon as you remember. Unless you are approaching the time of your next scheduled dose, in which case you should skip the missed dose and resume your normal schedule. Never double up without first consulting your physician or pharmacist, because the appropriate course of action depends entirely on which medication you are taking. Before I close, I want to be unambiguous about something. Blood pressure medication saves lives. The evidence supporting the treatment of hypertension is among the most robust in all of cardiovascular medicine. I am not suggesting you discontinue your medication. I am not suggesting your prescribing physician made an error. What I am telling you is that the conversation about timing, when to take your medication, what to avoid taking it with, and how to handle a missed dose, is a conversation that frequently does not occur during a 15-minute clinical appointment, and that gap in information carries real consequences for real patients. If you are over the age of 60 and currently taking blood pressure medication, or if someone you love is, here are 5 specific questions I encourage you to bring to your next appointment. First, should I be taking my medication in the morning or at bedtime? Second, are there foods, beverages, or supplements I should avoid around the time of my dose? Third, what is the correct course of action if I miss a dose? Fourth, is there a specific time of day when my blood pressure tends to be at its highest? And fifth, are there timing interactions between my blood pressure medication and my other prescriptions? Those 5 questions, asked clearly and directly, will do more for your cardiovascular protection than anything I can offer in a video format, because your physician has access to your complete medical history, and I do not. But I can give you the right questions to ask. I am Dr. Lee, 40 years in medicine, and this channel exists to give you the clinical conversation that should have happened in the exam room. Take your medications thoughtfully, understand the timing, and do not hesitate to ask your physician or pharmacist for the specifics that apply to you. I will see you in the next video.